lecturer is, again, we talked about, we've switched some people around. It's Dr. Moret. He's speaking on tendinopathy and diabetic foot ulcers. Dr. Moret, Professor of Orthopedics, Mayo Clinic, Rochester, Minnesota.
Well, thank you very much. Good afternoon. Excuse me. I have the enviable position of being the speaker right after a break. So I'm sure that, or I hope people will filter in instead of filter towards the bar. We'll be talking about two conditions that are so prevalent in your profession as to almost dominate it. And it'll be, the reason we're talking about two of them that are rather disparate is that there's a single technology that seems to be effective with both. And so if you learn that technology or have access to that technology, I think it will put you in a very good position to be able to treat your patients effectively, both with chronic refractory tendinopathy as well as with diabetic foot ulcers. I'm going to take a survey when the room gets a little bit more full to find out how many people take care of diabetic foot ulcers and chronic tendinopathy, but I assume almost everybody the latter, and many the former. So I'm aware that I have a legitimate concern that you should be aware of, and that is I'm the medical director for 10X, so I do have a potential conflict of interest depending upon what I say if it's not based on fact or evidence. As you all know, the problem that we have, by the way, I should tell you, I was in the foot clinic at Mayo for 7 years, so I practiced, although I'm an orthopedic surgeon, do joint reconstructions and trauma. I did do foot for 7 years, and so many of my opinions and comments relate to that experience, of course. And one of them that was very vivid is how I did not like to see patients with chronic tendinopathy because I did not have a good solution for them, and I didn't like them to keep coming back and me telling them to hang in there and to wait it out. It usually goes away. So one of the things I think that we've learned over the years, though, is that the treatment kind of varies as a function of the stage of the process. When you first see them, we all probably offer some form of eccentric exercise or modalities that seem to at least not cause any harm. And we know that they will tend to resolve with time. But as the patient gets more chronic and they are more refractory to whatever treatment modalities you're offering, I think we both, the treating physician as well as the patient, gets a little bit frustrated because they want some definitive answer so they can get their lives back, so to speak. It's interesting that there is actually a fairly good science that supports eccentric exercises, and the basic mechanism is that eccentric exercise does stimulate a healing response. And the definition of a chronic refractory tendinopathy is that condition in which the signal for the body to heal this as a physiologic process has been lost. So the treatment of chronic refractory tendinopathy, the real key to it is you're trying to signal the body to do what it's supposed to do, which is to heal the process. And eccentric exercises have been shown to probably be not an I guess most people still use cortisone, maybe not. I haven't used it since this article by Combs in 2013. That article found that at 1 year follow-up with a relatively large sample, prospective, randomized, blinded study, patients that had cortisone injection in and around the tendon did worse than those that did not, where the control group was just eccentric exercises. So that's bothersome if they're worse at a year. And then there a guy by the name of Hart from Canada did a meta-analysis and looked at 7 different studies, prospective randomized controlled studies, and found that in both, whether there was a control or no control, the control was physical therapy or there was no particular control, patients with cortisone did no better or worse in all 7 studies. Now, the reason these data bother me is in all the years in the Mayo Clinic, we've only won 1 Nobel Prize, and it was for the discovery of steroids, of all things. So it's a little bit frustrating not to be able to use the one thing you're really proud of that your clinic did years ago. But we still put it in the joints. It's still useful. How many people in the room use PRP? Objections, one or two? This is really popular in orthopedics, very popular in non-op sports. It's more expensive, as you know, or can be pretty expensive. There's no real proof of efficacy as of a few years ago, but now as more and more data is coming in, there is a statistically significant value, it is felt, according to the literature, for tennis elbow. But how many people are familiar with the Cochrane reports, the Cochrane meta-analyses? This is something that internal medicine relies heavily on. It's a way of analyzing the quality of the literature and then coming to an opinion as to whether or not the literature supports a certain treatment. And the Cochrane report supports this for only epicondylitis, says the data aren't adequate to justify it otherwise. But it's still very popular, you may know, even if you're not using it. And why? Well, it's safe. Yet people still pay for it out of pocket. In some places, it's as much as $2,000 a shot. That's coming down, but it is still out of pocket, and people are willing to do it because they get frustrated with the chronic refractory condition. This is an article that was in the American Journal of Sports Medicine that we helped design. And this is really important because it's the only article that I'm aware of that defines what chronic refractory tendinopathy is. And what we found was that a cohort over a 10-year period, over 2,000 patients, all in the Olmsted County where Rochester is, and all the treatment is taken care of, these patients are taken care of in facilities that we have the records for. So it's a very closed group, so we got pretty good data. And we found percent of patients their problem at about 6 months. But what we found that nobody knew, it's never been reported in the literature, and I think it's relevant to you even though this was epicondylitis. If they're still hurting at 6 months, the average time for that large cohort, 2,000 patients, 20% of them to get over it was 2 years. So that says that if you're seeing a patient in your office, obviously, and you've been doing eccentric exercise or been doing non-operative modalities and trying to get them to heal, and they're still hurting at 6 months, and particularly what's important is this slide, and that is, if at 3 months they're making progress, that's good. And then you follow them, and this is what 80% will do. But if at 3 months they're not responding much, then you have to ask yourself, is that what they're going to do in the next 3 months? Not very many of my patients do that. And so what I actually start doing is I start talking to the patient about a definitive treatment at 3 months if they're just not making any progress. If they are making progress, you just pat them on the head and let them keep going. So the 3-month point is when we start thinking about this definitive intervention. So what is definitive intervention? Well, I guess we'd all have a little bit different views, but I think we'd probably agree if you could definitively treat something with one effort, not have them coming back over and over and over again. It doesn't need a chronic exercise program that may have problems with compliance. If you could intervene early so that they're not hanging out to dry, so to speak, while you're waiting for the body to spontaneously heal. If you could treat them in an environment that's well tolerated, such as an office with local anesthesia, and if you had reliable outcomes that were 80 to 90% or something in that range, and if you could actually drive down the cost, how many new technologies are out there, nothing against the vendors, of course, that actually drives down the cost of care? Now, how does this drive down the cost of care? Well, if you can get a person back to work, that's a dramatic decrease in the burden to society. And then the real trump card of any new technology, in my opinion, is how safe is it? And the little test I ask people is, say, if I could offer you a procedure that's 100% successful, every patient you do it on is going to get well, but 1 out of 10 will have a major complication that you have to treat. How many would adopt that technology? But we've already seen with PRP, it's effective about 60% of the time. And it's very widely accepted because it's safe. It's the patient's own blood. So in my mind, at least, the one feature of a new technology that trumps all is its safety factor. Now, when we talk about how this is accomplished, it's accomplished with wave therapy, wave treatment. And you're all familiar with Topaz. How many people have used Topaz in the room in the past? Are you still using it? Some? No? I haven't found too many people that still use it. But that was an effort to use ultrasonic energy in a little different way. It was invasive. Under the anesthesia, there were some tendon ruptures. There were problems with it. So this really is not what we're talking about. So when we talk about an ultrasonic treatment for tendinopathy, and you say, well, you know, I know what it's about because I do extracorporeal shockwave or I do Topaz. That's not what we're talking about. What we're talking about is something that's about as complicated as a cortisone injection. It's just that the needle is an ultrasonic probe. And it has some other features that make it truly unique and I think account for its efficacy. How many people have heard of phacoemulsification, or phaco? Anybody? That's the treatment for cataracts. The local anesthetic, you go in and local anesthetic, they emulsify the cataract, suck it out, and you walk out. Local anesthesia. And it totally changed the treatment paradigm. It's been around about 25 years, about almost 30 years now. And that was the predicate that we used to justify for tendinopathy in terms of its safety profile. Because phaco is very safe, it's very effective. What's different about this particular treatment is the ultrasonic probe is hollow. And so when you're treating the patient with this ultrasonic energy, you emulsify or cut through the degenerative tissue, and then the degenerative tissue gets sucked out. So it's removed, just like a surgical procedure. And you can see the collection bag there where the debris is. There's a sleeve along the outside of the probe that allows irrigation to flow so it keeps the tip cool and therefore eliminates or lessens the likelihood of burn or thermal damage. And so these are the unique patented features of this approach. And so in addition to, the concept is, in addition to removing the tissue, just having ultrasonic energy might be something like eccentric exercises. That is, stimulating a healing response. And when you get done, it lessens the stage of tendinopathy because when you're done, all the patients you've treated are at the same stage. They've just been stimulated and you have removed the degenerative tissue. So you are having all your patients kind of at the same starting point at that stage. There's an energy console that delivers the energy, and the energy has been patented and is optimized to be very effective against the mechanical properties of degenerative tissue, including plantar fascia. But it is not very good at all against normal tissue. And so this is a demonstration we did at Mayo. In the upper right-hand corner is a normal tendon. And right next to that normal tendon, I put the probe on the tissue for 7 seconds without moving it. You always move it, so you don't ever leave the probe in one spot. And you can see that the staining is a little different, but you can see there's some waviness in the tendon, but you don't see any ruptures. So we'll look at our clinical outcomes to see if that demonstration is accurately with the patient. We did do an animal study. One of my former fellows at the University of Kentucky did an animal rabbit model, and what he demonstrated is that the tendon was digested. The patient was treated with 10X, and in 3 weeks, the type 1 and type 3 collagen returned to normal, and the tendon reconstituted. So this would suggest that this, in fact, does seem to stimulate a healing response. And in an example of the void that was created by the probe by removing the degenerative tissue. And this is the first study. Sorry, I'm having a lot of trouble, as you can tell, with that. I don't know what to do about the audio. But this was the first study done, and it was done in Singapore, another one of our fellows, but Singapore is a very closed society. They don't move around a lot, so it's a very good place to do studies. The University of Singapore General Hospital is a very, very first world hospital affiliated with Duke. In any event, these patients were followed not only for 12 months, but for 36 months, all 20 patients. And these are the visual analog score for pain came to 0, and the DASH score, which is a standard of upper extremity function, returned to normal. And so this was published first at a year and then followed up at 3 years. So that shows very effective patient effectiveness. And they also did ultrasound assessments on all these patients, and here's a preoperative at 0 and then a final 3-year, and you can see the tendon looks like it's reconstituted. So we do have pretty good data that shows that this is effective in treating the hypoechoic area, and we have animal data that suggests how it works, and then we have ultrasound data that suggests that the tendon does reconstitute. So as we mentioned, and I mentioned in my disclosure, I think it's important to know what the science is and what the documentation is. And we have 30 publications to date. 15 of them are case studies. We do not have a prospective randomized control study yet, but we have one that's just being submitted. And you can see this is from over the years, various types of presentations to the community, and several of these articles are by podiatrists. And one of these is as I just mentioned, the animal model, and then the epicondylitis. The bottom epicondylitis study is a Mayo study, which was a prospective study and found about 90% success. Jumper's knees, 2 studies. Between the two, it's over 90%, and this one about a little less than that. And then Achilles insertionitis. This Lou Freed is a podiatrist in Phoenix. You may have heard of him. He's published some. And his partners, 26 patients with 92% success and mean follow-up of almost a year and a half. And Mahir Patel is an orthopedic surgeon trained at Hospital of Special Surgery in Ortho, Indiana. He looked up 12 patients. And then, interestingly enough, this guy Rasdin is an interventional radiologist, and he actually treated 100 plantar fascias over a period of time and followed about 2/3 of them for a year and found 90% were satisfied and had a satisfactory outcome. So it's pretty favorable down at the foot and ankle. We've summarized what we know in the literature from the cases we've done is that it hovers between 80, 85 to 90, maybe 95% successful. And so we think that that one criteria for a successful intervention is that it is effective. It's probably been demonstrated, at least it has in my practice, and I've done about 400 procedures of various anatomic sites. And this is what you can expect or what the patient can expect. About 1 out of 5 will have almost complete relief of symptoms right off the button. And I think that's because the pain the origins of the pain for chronic refractory tendinopathy is probably the cytokines that are neurovascularly mediated. And if this is sucking out the environment of the treatment, it's sucking out the cytokines, which means it'll quit hurting right away. And I have one patient I just treated about a week ago, a gluteus tendinopathy, and she said that as soon as the local anesthesia wore off, she never had any more pain. But that's only a small percentage. Usually it takes 2 to 3 months to see the full benefit. And if the patient doesn't say at 6 months they're a lot better and they're glad they had it and they don't need any more treatment, if that's the case, then they're a failure. So I allow patients to heal up to 6 months because I have about 1 in 10 that did seem to heal between the 3rd and the 6th month. And this is the distribution you'd be interested in. So in the 7 or 8 years we've been doing this, we've done about 85,000 procedures. We just recently started the gluteus and the shoulder with a new probe. I'll show that to you. But what I thought you'd be interested in is that about half of them are in your bailiwick. It's the tendinopathies and the plantar fasciitis. Accounts for almost half of what we do. And in my practice, probably the most successful patient I have is plantar fascia. And that when I was doing orthopedic kind of foot surgery, I never operate on these if I could avoid it or if I could help it, but I hated this diagnosis, and now I don't mind it at all because I think I've got a good solution for it. So what about the safety profile? I tried to emphasize how important that is. Well, the energy that comes off the probe is only a fraction of a millimeter, and the way it works is the energy propagates as a waveform through the tissue. this console is designed to cut off if it's not irrigating or if it's not aspirating. So unless all three functions are there, the energy isn't expended. And we do this under ultrasound visualization. How many people use ultrasound guided injections? Congratulations. So not many. Well, I would recommend you, if you're going to do this, you might want to learn it. It isn't that hard, and we're going to have a workshop with some ultrasound that you're welcome to come and try your hand, because I don't particularly care for ultrasound. I never did in my practice. But it's pretty easy. It's just skin and bone, and then there's a tendon attaching. I mean, how hard can it be? And so that's for the calcaneus and for plantar fascia. Very, very easy. So if you visualize the pathology, it's less likely you're sticking the probe in the wrong spot. And then it's the energy source, as I mentioned, is only effective against degenerative tissue. And so for those reasons, we would theorize that this is a pretty safe intervention. And this is how many complications we've had in 85,000 cases. And these are complications that require some treatment. And you can see that there's only been 3 tendon ruptures. One was on fluoroquinolone, 1 partial nerve injury maybe, only 2 infections, both required IND, and they were both down at the foot, by the way. They weren't at the shoulder, gluteus, or elbow. We have had some probe breakage that has now been solved with a new design, but these 10 were embedded in the tissue, and they had to make it a little incision to go and get them out. So we added that as a complication because it added some morbidity to the patient. And so I would conclude as a surgeon that if you can do 85,000 of something and have to address only 18 problems, that's a safe intervention. There's 3 probes now. We started with the TX1 and generated probably 20 or 30,000 with that, and then the TX2 goes deeper with the shoulder and the gluteus that you wouldn't be interested in particularly. But a lot of podiatrists use the TX2 for the plantar fascia because it's easier to get to than the TX1. It's a longer probe. And we just are introducing now something that in this slide is called the TX hard tissue, HT, but it'll be commercially known as TX bone. And TX bone actually removes osteophytes and spurs. So in addition to treating the tendinopathy, if you feel as though the osteophyte or the spur is a contributing factor, it may or may not be, of course, but if you feel like it is, and the patient sees the x-ray and say, "Doctor, what's that?" And you say, "Well, that's a spur." But that's not causing a problem. I'll just get rid of the tendinopathy. You know how that goes. They keep looking up at the x-ray. If they're no better, they're saying, "Well, that spur's still there." So you can take it off if either you think it needs to be or if the patient just has to have it. Here's an example of the newer probe, the bone probe. This is obviously a shoulder rotator cuff tendinopathy. It's real common to get calcific tendinitis in the shoulder, and it's always in the supraspinatus just as it attaches, almost always. And here you can see a post-procedure. I think this is at 3 months, and it's just, you would never know that the patient had that problem. And here's another patient viewing it from the side. The first one was more mature. This is a less mature, but you can see completely removed. And then here's one that you might be interested in. This is a heel spur, obviously, off the calcaneus. And you'd be interested, he started standing on his head, I guess, for this x-ray. But this is the spur, and you can see that it's been taken down. This was done by Dr. Freed, who is a friend of mine, a podiatrist from Phoenix. And so I think, based on our experience, tendinopathy in the future is just going to be treated in some way with this kind of a device. It may not be this company, it may not be done exactly this way, but it just changes everything as far as I am concerned in terms of these patients. I think the diseased tissue will be removed with a minimally invasive puncture site because we're doing it now. I think you can do it in the clinic setting. The Singapore study, the first study that showed such good results, they were all done in an office setting under local anesthesia. There's no reason not to offer the intervention early. If you know at 3 months they're not getting much better and you know the data that shows they're in for the long haul. And if you've got a safe intervention, you can offer earlier. If you've got a lot of problems and a lot of complications, you want to hold off surgical intervention because of the risk-benefit ratio. And I think it will be cost-effective, particularly in getting people back to work. And if you believe in PRP, which it didn't see very many hands go up, but the orthopedic surgeons use it like a madman, as do the non-op sports people. And if you believe in that, you could still use it, but you could use it as an adjunct to this if this doesn't seem to be working. So I think that's the future of tendinopathy as I see it over time. So in summary, what I would call this treatment is a percutaneous treatment that's technically similar to a cortisone injection, but with the efficacy of surgery, but without the cost or morbidity. So I think in those few words, that summarizes this particular application for this particular disease process. Let me just show you an example. Plantar fascia. Like I say, I really get off on this now because it's fun to treat. Use a long axis view, that's what this is called, so you can see the fascia streaming into the medial tubercle of the calcaneus. And as you know, diseased plantar fascia may not be hypoechoic, but it's thickened. And if it's more than about 4 or 5 millimeters thicker than the other side, it's considered abnormal. This is what a healthy plantar fascia looks like. So you confirm the diagnosis, and I never like to put puncture sites on the plantar aspect because I think it almost hurt me as much as the patient. I just hated to see him grimace, and then I grimace, and then, you know. So I like to go in from the side. They don't feel it as much, and it's easy to do. This is called short axis. There weren't very many hands went up without ultrasound. So what you're doing is you're looking at the medial tubercle and the plantar fascia in that thickened area. When that probe comes in, it cuts the plane of the ultrasound sensor as a dot, a shiny white dot. So it's real easy to locate where you are, and then you just adjust your line of attack, so to speak, until you're right on the medial tubercle. And then when I'm treating, I use both what's called the long axis, looking at the pathology, and then short axis, and this makes sure I get all the way, short axis for the pathology, and make sure I get all the way across the medial tubercle. So it takes about a total of 3 minutes for the energy time, maybe 2. And then you close with a steri-strip. I usually just give them Tylenol and a walking boot if they have one. If they don't have one, I don't necessarily prescribe one. Here's an Achilles substance in the watershed area. I usually use 2 puncture sites on these because they're pretty large areas. We've only had one rupture, and that was a lady that was on fluoroquinolines, was offered surgery because they said you have an impending rupture. They tried this procedure, and she ruptured it a month later. She didn't consider it a complication, but I put it in the list because at that time we only had 1 or 2, and I needed complications. In this, I'd usually use 2 puncture sites to make sure I get all the way through the lesion. And insertionitis, I go on both sides usually, because usually they're hurting all the way across. Here you can see a pretty good view of the Achilles. See, it almost looks like plantar fascia. Here's the probe coming in, hypoechoic area, that's what's really hurting. Some calcification of spur coming off. And you can see the spurs being knocked off along with the treating of the hypoechoic area. And here's another more dramatic example of a very prominent spur, and it's been pulverized. And these, in my experience, usually resorb. If you can knock them off to this level and pepper them to this extent, over time this resorbs. It tends not to recur. The technique, we do a clinical exam. Obviously, I mark the point of maximum tenderness. Then I do ultrasound to confirm the location of the lesion and the existence of the lesion. Prep and drape like a steroid injection. And I use local anesthesia, and I go straight to bone because you're all familiar with dry needling, I suspect. So I kind of dry needle with my local anesthesia. I don't see any harm in it. You're trying to get marrow to bleed into the area because that's where the healing factors are. So we then incise the skin and fascia with an 11-blade knife. It's just enough to slide the probe in without having too much resistance to it. And then it's about a 3 to 5 millimeter back and forth motion. Again, if you're interested, we'll have the cadaver lab from 6 to 9, I guess, or so, and you can get a feel for it. The visual clues to completeness, if you're dealing with a hypoechoic lesion, it turns white. It's an artifact. They're nitrogen bubbles, we think. So if you're treating a black lesion, which is hypoechoic, and it turns white, that means that lesion has seen all the energy, or has seen energy, and that should be all you have to do. The treatment time in my patients, about 400 of them, it's been 1 minute is usually for epicondylitis, tennis elbow. The longest is a gluteus or a plantar fascia. Plantar fascia is usually about 2 minutes. I rarely, I don't know if I've ever gone to 3 minutes. The recovery, ice and Tylenol. I don't use narcotics after this. I tell them to rest for 3 days to let the blood clots set and get sticky, so we're stimulating healing. Then I tell them to be sedentary for about 3 weeks. And if they're doing good, I let them resume normal activity between 3 and 6 weeks. And if they're really doing well at 6 weeks, then I let them start introducing the things that caused it to begin with. So usually full activity. For a jumper's knee, which you don't use, I don't think many of you treat patellotendinitis, but I go about twice as long because of some implications. If that thing pulls off, that's a bad day for everybody, particularly, well, for everybody. I don't typically use adjuncts. I'm trying to keep the costs down, and I don't think they're needed, but that's an area that some clinics are studying to see if post-procedure instruction and discipline or programs are beneficial. And then I only work 1 day a week in Texas, so I just have the patients call me. And so it doesn't clog the waiting room for those that are in active practice and all that. They can call. But the art of medicine would suggest you ought to see them once at 3 weeks. Just people want to be seen if you've done something to them. So I'd see them at 3 weeks and then say, from here on, come back if you got a problem. Otherwise, give me a call. And so if they have a problem, they come and see me on my Mondays, which is when I'm in the clinic. I've redone, I think, 7 patients that of the several hundred that I've done who I think I failed in my treatment or they recurred. So let me stop there and just see if there's any questions about that, because I have another really exciting topic that's going to blow you away. This makes this look like it's the child's play compared to what it can do for diabetic foot ulcers. Any questions? Yes, ma'am. Yes. We've treated trochanteric bursitis, olecranon bursitis, and bursitis around the calcaneus and the Achilles and its attachment. And if you feel as though in your exam that the bursitis is a significant component, yes, just put the probe in. And what we think happens is it propagates through the fluid, and I guess I don't know exactly what it's doing, but it's kind of emulsifying the synovial cells of the sac. So it seems to be pretty effective. Some of the people, particularly the podiatrists, have kind of ventured around like I guess podiatrists do, and they've been using it for a perineal tendinopathy, and stuck one of them showed me, stuck a scope up the sheath. It was all red and beefy, and then they put the probe up and hit the pedal, and it just turned white. And a guy by the name of Sussman from Tufts is writing up his experience. He has, I think, about 30 of these. And he said there's over 90% that it just goes away. So there are some other applications to it, like a bursitis.
Question?
Yep.
How does this compare in terms of success rate with the ECAP, Chaplain? Do you know?
No, I haven't. Well, I know that the literature is kind of variable on the, you're talking about extracorporeal shock wave?
Correct.
Well, the extracorporeal shock wave is a function of so many variables. I think one of them is this microphone or that speaker. It's a function of the energy level, how often you treat them, how long you treat them, what stage of the tendinopathy they're in. So the literature that I have read on this, which most of it is epicondylitis and Achilles insertionitis are the two most common sites. It's somewhat unpredictable, and it is uncomfortable, and it costs. There's repetitive treatments that are required. So for that reason, I really like you come in and you're one and done. Yes.
There's a pretty significant equinus performance present. Are you doing a session or something?
Yes, I don't do those, but the foot guys do. And my friend Lou Freed, who's the podiatrist in Phoenix. And, well, I'll just show you Lou while we're talking. There's Lou. That's what he does. And that's what the podiatrists typically do for an equinus. They do a recession, and if they got the tendinopathy, they can treat that too. Okay, well, let's go on, because this, I've been in my discipline in orthopedic surgeon since I finished my training, which is more than a few years ago, as you can imagine. And this is the most exciting thing I've seen, other than total joint replacement and arthroscopy. I mean that. And it's hard to contain yourself. So we're talking about the diabetic foot ulcer now, and you may know the numbers, but if you don't, the burden is just unbelievable. It's over $11 billion plus minus $2 billion, so $11 billion a year for diabetes. And Medicare expense per patient, diabetic patient, is $33,000 per patient. I mean, how can we, and the rate is going up at what, 3 to 5% a year. So that's not good. This one guy by the name of Rice did a really good study and said, well, okay, and his baseline was 28,000, not 33, but he said, of that, how much is due to an ulcer if you have an ulcer? And he found, lo and behold, that almost half of it, almost 12K, was due to the ulcer. So if diabetes is very, very expensive to care for, and if they get a diabetic foot ulcer, of course, we all know that that's a pain for everybody. But the actual expenditure is about 40% of the total bill. Now that we're getting a few more people in the room, we should have given this talk at a bar, I think. But anyhow, how many people treat diabetic foot ulcers? Yeah, the bane of your existence, I suspect, because these patients are chronically overweight, as you know. They're non-compliant. I've taken care of them too in that other life. Private insurance even has a bigger problem in a sense, because they only put out $26K a year on the diabetic patient, but well 60% of their bill is the diabetic foot ulcer. So just to put it in perspective, everybody knows it's a big price tag, but it's real big. What do we do for it now? So the other thing is, where are the expenses coming from? Well, if you're doing various grafts, biologically altered grafts, or scientifically altered allograft or whatever, synthetic, you can see the apograft, the dermograft, and the OASIS at the lower end of the scale, a factor of 10 between OASIS and dermograft. The healing rate at 9 months without recurrence has been quoted at about 60%. And you know how expensive they are, and you know how often you have to do them, and you know they recur. And this is the problem. This is the predicate against we have to compare a definitive treatment. So same idea as the tendinopathy. What would be ideal? What would happen if you could treat them one time? Pat them on the head. You'd have to see them again. You have to offload them, but just one time. Cool. And you could learn it just by sitting down and watching somebody do it. And you can do it easily, like in the office, really. You don't need a sophisticated environment. And you can do almost all the ulcers, at least in a certain category. Let's say, it's not all the ulcers, but the ones that are problematic, that are 3 centimeters in diameter or so on the metatarsal heads. And if you could obtain complete healing of these ulcers in a safe, durable fashion that wasn't too expensive. Well, that is treatment nirvana, and that, I think, is what's happening. So we use a similar type of probe. It's got some different characteristics. And the science of this, you have to address the features of the pathology, obviously. And so what are they? Well, they're avascular. Why are they avascular? Diabetes is a disease of the small vessels. We know that, basement membrane. We also know that they get neurotrophic, and they put pressure on the osseous prominences, and that causes them to create a localized area of ischemia due to the pressure. It's a pressure necrosis phenomenon associated with the neurotrophism. We also know that once they break down, it's not uncommon to get infected, and it's not uncommon to be polymicrobially infected, and those are very difficult cases to manage, as you all know. And then what kind of a patient are we treating? We're not treating that young, fit triathlete. We're treating BMIs in the 40-plus range in patients that have not had good success, and they just don't care what you tell them. That kind of characterizes it, as you all know. So the mechanism of action, the hypothesis is, I'll show you a slide. Ultrasound promotes neovascularity. It promotes perfusion. So that's good. That's what you need if you're going to try to heal an ulcer. And it can remove the bony prominence. We showed you how it can remove calcium from tendinopathy. It can remove the bony prominence. And when you knock off the bone in the metatarsal head, the condyles, what happens? It bleeds. And what is that blood? That's marrow blood. And that's where you get TGF-beta and the other healing proteins. So you're actually, it's almost like a PRP injection. It's just not concentrated. And interestingly enough, bacterial ultrasound itself is bactericidal. That's how you sterilize food. Different energy sources. But so if you could have something that isn't going to make it any worse, let's say, and could even help decrease the bacterial burden, that could be attractive. And so the same person that did the animal study did a study that just got accepted in the Biomedical Journal of Science Technical Research. And he demonstrated that the energy coming out of the 10X probe is bactericidal, and it's time dependent. So the longer you keep it going, the more bactericidal it is. If you put it in the test tube for 2 minutes, it kills 70% of the organisms. It doesn't go to zero, but it does show that it tends to be bactericidal. And then this is a study from plastic surgical literature that shows the neovascularity after ultrasound treatment in an experimental animal. And this is a study I did at Mayo. It's not really a study, it's a demonstration. I was treating a diabetic ulcer, and this has been present for 2 years and just wouldn't heal. So we did something called a SPIES. Anybody heard of the SPIES scan? Do you guys use it at all, guys and ladies? Plastic surgeons use it a lot to see if the flaps they're creating are viable, and they can help design the base of the pedicle. And so they inject a dye, a radioisotope, and then they have a scanner that scans and it changes color. And ischemia is yellow and perfusion is pink and red. And it's kind of color graded. So we treated this patient in the way that I'm going to show you in a second. And as soon as I scanned him before, treated him, and then as soon as I was done, we took the probe out and took the scanner and brought it back in. And you can see in a matter of just a few minutes that this wound went from an ischemic wound to a perfused wound on the table instantly. So this helps explain something that you won't believe, and that's okay. I didn't believe it either, is how fast they heal. Not only they heal really fast, and I think this is one of the reasons. The probe is getting rid of that real thick scar that's avascular and preventing any vascularity to come into the area. That's one of the features, that ring of cicatricial scar. So here's kind of the concept. The probe goes in and we remove that real thick, dense avascular scar that prevents any circulation from getting into the ulcer. And once you've done that through one portal, you then continue to the bone and you start shaving off, or this is usually pretty soft, so you can penetrate it and start coring it out, and like you do for a bunion sometime, and then collapse it after you've thinned it out. But that's the concept. You do not see the probe through the ulcer. You never see the probe. So you're not washing the ulcer, and you're not sticking the probe through the ulcer, as you'll see in a second. So you determine the number of portals that are used, and the portals are outside the ulcer, goes under the ulcer, and you're headed for the scar, and then through the scar you're headed for bone. And depending upon the size, usually it's 4. If it's small, you can do 2. But you should always do more than 1, because the portal make them both at the same time, or 3 at the same time, or 4, because you want the e-flow, the excess fluid to flow out. You don't want to build up a lot of free fluid in the lesion. And then we use a linear redirection. That is, you just keep peppering it and bring it out, and keep kind of fanning it as you bring it back and forth. And you penetrate the bony prominence, as I mentioned, remove the prominence, and then you collapse it with direct pressure. And then when you're all done, you turn off the fluid irrigation, turn off the energy, and you just aspirate it, try to get rid of the excess fluid and debris. So here's an example. This could have been done with 2 puncture sites, but we just wanted to show the 4 quadrants. So you stay away from the ulcer. You're about 1 centimeter away from the ulcer. Now, here we go. These are Lou Freed's cases. So this is the patient. They're all the same kind of. So this has been present for over a year. He had quite a number of traditional efforts. He had 1 treatment. It lasted just under 4 minutes. He went from this ulcer that had been there for a year, refractory to all these treatments, and that's what it looks like at 41 days. And that has not recurred in 4 years. This is the patient, BMI of 49, God bless her, and has this relatively small ulcer, but has been present for a year. Same debridements, coverings, inserts, offloading, energy time 2.5 minutes. It took less than 2 weeks to get to this state, and no recurrence in over a year. This is my favorite one because I don't understand it at all, but the patient had this for 1.5 years. BMI not so bad, probably could be a model, I suppose. They had serial debridements and it kept breaking down, and this was a 7-minute treatment. And actually, I must tell you, this did not heal in 14 days. They swear it healed in 10. And I can't believe it, so I just added 4 days to that slide. Now that's true, because I went out to Phoenix twice to see these patients because I couldn't believe them. And then this is important because this shows that the technology is easily transferred to somebody else like you guys. Because this is a podiatrist that heard Lou talk, and he's from Rhode Island, and just in January he treated this ulcer that he couldn't get healed for 2 years, and that's not a good-looking ulcer. And this is it at 14 days. And this is the guy that I don't even think he came out and visited Lou. I think he just heard him talk, and we have a video on it. And so that says that the learning curve is pretty steep. You know, people use that term wrong. Steep means you learn very fast. So the learning curve is pretty straightforward. If you know how to treat a diabetic foot ulcer, it's easy because the principles are all the same. You still offload, you still do good wound management. It's not a miracle. It just addresses the features of the diabetic foot ulcer. And I think Lou thinks that marrow leaking into the wound is why they heal so fast. So here's his experience. The first one he did was October of 2013. So he's done about 80 that satisfy our criteria, which is 3 centimeters in diameter or less. He's done more really big ones, but these are what we're recommending to do. These are MW classification of type 2 or type 3 ulcer, and the duration has to be more than 3 months. And he's done some that were greater than 3 years. The 76 out of 79 completely healed. And importantly, look at this. The recurrence rate following anywhere from 3 months to 4 years, following this sample from 3 months to 4 years, the 76 that healed, 4 recurred. The mean time to healing, he says, is 21 days. Now, the one thing to be aware of, it's not as easy as falling off a log in the sense that the diabetic patient is very vulnerable to infection, as you well know. And so you do have to give prophylactic antibiotics for these patients. And you got to watch them and make sure they don't get infected, because it may be that that treatment can be causing a problem. I'm going to show you an example. I think I have it here. Oh, no, I don't. Wait a minute. No. Shoot. There's a patient that developed cellulitis on the forefoot, and his wound was completely healed at 2 weeks, but he came in with the cellulitis that has to be treated now. So I don't fully understand that, and I've talked to Lou a lot about it, but treat them with prophylactic antibiotics and keep an eye on them until they heal. So this is actually reimbursable, which is kind of good news for you as well as the patient, I guess. depending upon where you do them, you get a physician fee. This is the soft tissue debridement code that Lou uses. And then these are the bony codes. And you probably know this, but if you touch a bone and you knock it off, you can start getting some reasonable reimbursements that are enough to pay for the probe. So the overall, if you're doing it in the hospital, is a fairly decent reimbursement that justifies you doing it and allows you to introduce it into your practice. So in my opinion, as I told you before, of all the stuff I've seen in my career, this is probably the third most impressive I've seen. I think it changes everything. And that's where I'm going home to tomorrow. Thank you. Any questions? No questions? Yes.
When you use the probe to resorb the bone, how do you visually evaluate if you've taken enough bone out or if you've got it shaped the way you want it to be shaped when you're done?
That's a very good question, and I guess you heard, how do you tell if you've got enough bone and what it looks like? And we don't feel, I saw the response of how many people use ultrasound in the room, me and one other person, I think. So, but that's how you can do it. You can put an ultrasound on it if you're used to using ultrasound. Freed does that some. He usually palpates. I've done 3 of these, so I can't really speak from my own experience, but Lou puts his thumb on the ulcer. He never wants to see the probe. He's penetrating the bone, is hollowing it out, and now he's going over the surface of the condyle trying to sculpture it all flat. Then when he has it pretty well hollowed, he just pushes on it, and then he flat, and you can feel it's flat. So when you're all done, you palpate through the ulcer, and it should be flat. Yes, ma'am. Lou's never mentioned hematoma as such. He's modified his technique to turn it on aspirate when he's done to try to get rid of, as I mentioned earlier, the free fluid and the debris. But these feet will swell, and that probably is part hematoma and part residual of the interstitial fluid that you've injected into it. But I've been talking to him about his complications and starting to add those up so we can balance the complications. And but he hasn't mentioned hematoma. But an interesting question. I'm sure they're there. Yes.
Is this technique that used on baseball players' elbows for problems that they may be having, pitchers in baseball?
Yes, and in the medical advisory board, I didn't show that slide because you're a podiatrist and I didn't think you cared. About that, but it's there's a guy by the name of Jimmy Andrews. Have you ever heard of Jimmy Andrews? He's the team doctor for the NFL. And Neil Elatrage, he operated on Brady. He's at Curlin Job Clinic where Frank Job was. And they're big users. They're on our medical advisory board. They're friends of mine. So it is being used in the professional athlete, the jumper's knee in the basketball player, and in the baseball player, and in the football player. It's been used in all of those. But we're not allowed to talk about it or mention their names without their permission. And we don't have enough money to pay them to mention their name. Yes, ma'am. Well, that's what I'm calling it. The way you would code it is if you're going to do an Achilles tendinopathy, let's say, it's a percutaneous ultrasonic partial tenotomy because you're not cutting all the way through, the Achilles tendon. So it's percutaneous ultrasonic tenotomy or partial fasciotomy.
Okay, but for these ulcerations underneath.
That's called debridement. It's a diabetic foot ulcer debridement, debriding the soft tissue and the bone, just what you do if you did it open with a scalpel. Yes, yeah. You can. We have.
What's the instrumentation called? What's it?
It's called a TX1, a TX2, or a TX bone. And Brian, do we have all 3 of those with us, or? So if you want to get your hands on it and see how it works, and even see how it works on the bone, we have a lab at 6 o'clock.
What do they
I think you ought to talk to the business. God, I think you ought to talk to the business guys about that. Yeah, they're disposable. So, but they don't cost a fraction of what we're paying to take care of a diabetic foot ulcer. It's minuscule compared. Yes, ma'am.
Have you used it on charcoal?
Yes, yes. There's one really impressive ulcer. When I first went down to Phoenix and I said, I got to see your cases. This patient couldn't come in, but he had no toes, he had just the stump. And he took a picture with his phone and sent it to me, and I rejected it because I couldn't see where the ulcer had been. So I said, put a circle around where the ulcer was and send it back to me. So honest, as God is my witness, I couldn't tell where the ulcer was. And he had no toes. I had that in my slide deck. I should have shown it. It's kind of impressive. Yes.
Because blood flow can be part of the issue that ulcer wasn't healing. Do you have a baseline blood flow test, ABIs, that you really want before you do this procedure, so that that's not going to be a factor?
We don't know what that is. This is being adopted by Kaiser Permanente. They're doing a pilot on it right now with some of those parameters so they can provide some science. This is all anecdote. This is a person's practice. But the reason I'm willing to show it is because this is in contrast to whatever else we're using, and it just doesn't work, and it's real expensive. So that's why I'm showing anecdote as if it's science. It's not science. It's got a scientific basis, but we don't have that. That's what we need to generate. We just got approval for the probe that removes bone in October. So we're just now starting to being able to talk about it. I think I missed some hands. I don't mean to. Yes. Well, it's an interesting question. We've talked about it, and I am reasonably sure in all of the patients that Lou did, and he's got a four-person group, that there have been some patients that had evidence of osteomyelitis, but our official position is we're recommending that or suggesting that's a contraindication. I actually don't think it is. I think it's a good treatment for it. But if you say it's an indication and it doesn't work, then you lose the ability to kind of define where it does work, because people say that thing doesn't work. So we can't say, officially that's a contraindication. If I had a patient with osteomyelitis of the met head and an ulcer, would I do it open, or would I do it this way? I do it this way. And if that didn't work, I might do it open, but then we're probably looking at amputation. Yes.
So this thing preferentially destroys necrotic tissue.
Yes.
Is that right?
Yes.
And it will also destroy bone.
Yes.
Okay. So you can use it like you would a burr or something, except that it operates preferentially. And you've got a cannula there that sucks out the damaged tissue that you destroyed. Right?
Yes, that's it.
And then you've got bleeding that's left over, and that's what you see as your blood flow.
Yes.
So the underlying vasculature to the foot, say, is unaffected. It's just the local area that you're treating where they've got the ulcer.
Yes, it's hard to explain that scan that I showed, how's it instantly perfused, except to say once you've gotten rid of that cicatricial scar that has no circulation, then that is allowing the blood to come into the capillaries that are already there and perfusing the area. You're sure in the period you're treating this, you're not growing new capillaries. So it's just like removing a barrier, I think. But I was impressed with it, and because I can't understand why they heal so fast, to be honest with you.
It sounds like what you're doing is you're removing everything that doesn't have the ability to heal by preferentially destroying that vascular tissue.
That's exactly right. The mechanical properties of normal tissue, it goes on a harmonic resonance. And necrotic tissue has a different harmonic resonance than normal tissue. And so it's almost like a smart bomb. It can seek out, and the patented ultrasonic frequency is very effective against the mechanical properties of necrotic tissue and scar tissue. Yep.
Is
Oh, yeah, way back.
Have you ever taken out a fractured os perineum?
Not with this. But I do know that in some of these ulcers, there are sesamoids involved. In one of the cases that I saw Lou do, he took the sesamoid out with the probe. So you can remove it. Yes. Oh, yes.
When you're taking out something, either due to epicondylitis or something that has an osteophyte, are you just using one tip, say like the bone tips?
Yeah, when I'm doing tendinopathy, I use a TX2 almost all the time. The new probe, the TX bone, that is really aggressive. I mean, it takes bone out. And so I want to reserve that for bone problems for the most part.
But the TS2 will take out bone also?
Yes, it will. The shoulder that I showed you, the two shoulders were both TX2s. Okay.
Yep. Okay, hey, I just want to say that there are going to be 3 excellent workshops tonight. The biopsy, the 10X, and then the right medical sawbone. People who want to stay in here for the biopsy, we're going to have you leave and come back around to get scanned over there. So we'll go over that at the end there. Our next lecturer is favorite for the No Nonsense seminar, Roger Marzano. He's going to be talking on kinesiology and bracing of the lower extremity. And he's with, how do you say that? Yank? Yank.
Yank Bionic. You know the drill.
Oops.
I have it on. Yep, it sounds like it. Okay. Good afternoon. Thanks for the hearty few that decided to stick around and listen to me flap my lips again for the 23rd year in a row I've been at this program. So this is more near and dear to me than it is any orthotic and prosthetic and other programs that I'm involved in, because I know 70% of the people in the crowd and have helped take care of your patients. So I'm blessed, believe me. I'm very, very happy to be here. So when Dr. Hintz and I said, hey, Raj, let's figure out something you haven't talked on before, I said, well, what's that? In 23 years, I've talked on each topic of the foot and ankle 4 times. So I wanted to talk about pathologies that doesn't involve the foot and ankle that you guys can get paid on doing custom foot orthotics for. I do it every day. All of these diagnoses that you have listed right here, I build custom foot orthotics for, get paid by insurers for custom foot orthotics for the treatment of these pathologies. So this is an additional tool, an additional diagnoses that you need to look at in your office, because 70% of your patients that you see probably have one of these conditions, as well as the athletic world is exploding. I'm seeing the 55-year-old guy that decides that he's 35 pounds overweight and wants to start jogging and gets shin splints in attempting to do that. So these diagnoses are very popular and very, very treatable with custom foot orthoses. And I'm not talking about bracing, I'm talking about straight foot orthoses. So the first one I'm going to talk about, because you probably have kids that have been diagnosed with this condition called patellofemoral pain syndrome. So these people present with pain in the knee due to patellar tracking issues seen with greater Q angles. So in preparing for this talk, it was interesting the number of papers I had to read to show the efficacy of foot orthotics for the treatment of patellofemoral pain. But do you realize that's the frontline treatment in physical therapy? If they see a child or adolescent or an adult with patellofemoral pain syndrome, the first thing they're doing is dispensing custom foot orthotics for those patients. That's the first thing you guys should be doing. You're seeing people with knee pain every single day in your practice. You don't necessarily have to know the exact etiology of it, but you can certainly tell that a foot's overpronated or that that young adolescent has an excessive amount of valgum. So if you think about the Q angle, you can see right here, males it's usually 10 degrees, females it's 15 degrees, because most females have either genu valgum or tibial valgum. and most males have tibial varum or genu varum. So I treat a greater number of females for this condition than I do males, but it's not exclusively that way. But it's as simple as this. The Q angle is increased because of internal rotation of the tibia. And how does the tibia internally rotate? With excessive pronation. And you can see it all day long. So the tibia rotates medially, internally, and guess what? The patella follows the pull of the quadriceps. So the patella moves laterally, and it's now grinding away. You may have heard the term chondromalacia. That's lumped into the patellofemoral pain syndrome group. I can tell you that I'm suffering from chondromalacia right now because of my kneecaps getting lax in that joint. I have laterally posted foot orthotics because I have a cavus foot structure, and that helps me with my chondromalacia. So I'm living proof that foot orthotics can help with this. But the bottom line is, if you see that patient in your office and they're saying, oh my God, you know, I just finished this marathon, my knee's killing me, I got chondromalacia, and you say to them, are you wearing custom foot orthotics? You have a pretty good degree of pronation. You'd be shocked how many people aren't wearing foot orthotics, aren't even running in the correct shoes. They're running in minimalist running shoes, and they're overpronators. So there's a whole new world of footwear out there, particularly in the running population for those people, but I think frontline treatment in your office for that athlete with knee pain should be custom foot orthotics, out of the box. And I can tell you that on an average, I looked this week at my ICD-9 codes for the orthotics that I dispensed this week, and for the diagnoses I listed in this talk, myself, I dispensed 18 pair of foot orthotics for these diagnoses. Had absolutely nothing to do with saying they had posterior tibial tendonitis, plantar fasciitis. This is the new world of exercise that we're getting into. So because we see it more in the females than we do in the males, sometimes it's erratic in the pain. It can be lateral, medial, or underneath the patella, and it's reproduced with flexion. They can feel it a lot of times with flexion of their knee because that's when their patella is not tracking in the patellofemoral groove in the anterior aspect of the femur. So you're going to see that. You can prescribe physical therapy, but more than likely, if you're seeing that patient, they've probably already done physical therapy for this. But as you know, it doesn't matter who the population is. I see patients every day that get prescribed physical therapy for stretching, and I literally sit down and ask them and say, how compliant have you been doing your exercises? They're like the regular population, folks. They go 1 or 2 times, or you prescribed it, and guess what? They had a $40 copay that they have to pay each time they go to physical therapy, and then they come in and complain to me that they went to physical therapy, and the PTA said, here, get on this machine, start doing this quadricep, and went over and saw 4 additional patients at that time, and they paid $40 to use that piece of equipment in the therapy department. So many times, physical therapy, it should be used, and these people, by the time you're seeing them, have probably already failed physical therapy or are no longer going with physical therapy, and the first thing you should do is look inside their shoes and see what it is they're actually wearing. There's been a ton of studies. I went through each one of these pathologies and tried to pull the studies that supported the use of custom foot orthoses for proximal pathologies, pathologies that aren't anything to do with a diagnosis in the foot. And believe it or not, the one right out of the box, from 1986, said that how big an influence the foot orthotics do on the Q angle of the knees. And it's not rocket science, folks. The knee the foot's attached to the ankles, attached to the knee, and this has a huge impact. Unfortunately, most of the papers were done by physical therapists as well as physical therapy practices, but there's still plenty of sports medicine, individual podiatrists out there that are doing a lot of this work, and I just think it's something that we all could be doing more. So when you're seeing these patients with patellofemoral syndrome, again, most of them are going to be female. 60 to 70% of my office are female patients because of their genu valgum. Many of them are ligaminously lax in general. But what I found is that you need to not only post the hind foot in your orthotic, but you need to post the forefoot, because the knee is in full extension at heel off and at heel strike. So your heel post works great at heel strike, but in the forefoot, when they go to overpronate because your orthotic's coming off the ground, you need to bring the ground up to that medial surface. So I can tell you the orthotics that fail are oftentimes the physical therapy done cookie cutter orthotic that has no posting whatsoever on the forefoot. Most of these patients have been overpronating for a while. They either have hypermobility of the first ray or forefoot varus present, and it's never posted accordingly in the orthotic. So remember, when I think about orthotics for this patient population, the more flexible the foot is, the more rigid the orthotic should be. And the more rigid the foot is, the more flexible the orthotic should be. So if you're thinking about that, just be sure you key in on the forefoot to hind foot alignment, because most of the orthotics that fail that I reproduce for someone that has patellofemoral syndrome, and it's not just adolescents, it's not just kids, it's collegiate runners, it's a ton of these athletes, they never have forefoot posted orthotics. So just think of that the next time you're sending them off to your lab. Some people do well with a knee brace. This is a unique design. This is a web brace. That's an entire elastomer that's on the front of that knee. It's kind of cool. It's got a thermoplastic hinge on each side so you can get paid for it. But more importantly, the elastomer contours to the leg so that the kneecap is being harnessed all the way through the degrees of flexion and extension. Sometimes I have to use this in conjunction with foot orthotics. Of the patellar control knee devices that I've seen out there, this web design has been the most user-friendly to the patients, and it's nice because it doesn't stink. Most of these knee sleeves, you can smell them before you see them. So these things are an elastomer design. They can wear it bare-skinned, and it actually helps with suspension. So in patellofemoral syndrome, 70% of the time I can fix it with just custom foot orthotics, but 30% of the time I also have to use some type of knee orthosis as well because of the ligamentous laxity of the knee. This was a real tough one to sometimes fix on these patients, iliotibial band syndrome. And when I was reviewing all these pathologies that I use foot orthotics for, particularly above the foot, it's interesting. They turn into, most of them are coined a syndrome because it's kind of like plantar fasciitis. They just keep coming back and it keeps happening. And most of the time it keeps happening because A, either they're not wearing custom foot orthotics, or B, they're not following up with their therapy protocol. Physical therapy works with these patients if they stick with it and if you can give them something to do at home. But iliotibial band syndrome presents with pain near the lateral surface of the femoral epicondyle and near the head of the fibula. So it's very specific, very pinpoint pain. It doesn't travel up the leg. You can see the iliotibial band is a very large, expansive a piece of tissue. And it has a very large insertion, but it's also very strong. But imagine what happens is with flexion and extension, if the tibia is internally rotated and the femur is following that tibia because of overpronation, you now have a band that's flicking back and forth that femur. Excessive hip and knee motion in the frontal and transverse planes. So think about what I just said. Transverse motion that takes place at the knee is internal rotation of the tibia that comes along with pronation. You can't pronate without internally rotating your tibia. Doesn't happen. Try to do it. It doesn't happen. The tibia has to internally rotate for you to pronate. That's part of what that motion is. So if you can block some of the internal rotation of the tibia through blocking pronation, it automatically helps reduce that. So there's some theory that it's also just straight friction, But I can tell you the people that I treated 2 people this week with iliotibial band syndrome with foot orthotics. One patient had a cavus presentation, and it was a male with a lot of tibial varum. So with his cavus presentation and his tibial varum, he was too much on the outside, and I posted that orthotic laterally because that's what his foot told me to do. That helped his symptoms. It decreased the varus moment at the knee. But a young lady had feet that looked like 2x4s. If I cut her big toe off, you wouldn't know the difference from the left to the right foot. I mean, you couldn't tell there was any longitudinal arch. And she's a heck of a runner to boot. We popped the footer. I fit her Monday with her foot orthotics. On Wednesday, I got an email that said, Raj, I just wanted you to know I've ran 14 miles with no knee pain. None. Now, she'd been injected, had ultrasound done to the iliotibial band, 23 physical therapy visits, and I put foot orthotics in her shoes, and she says, why didn't someone do this before? It's what we know. When the only tool you have in your hands is a foot orthotic, I think the whole world needs them. So consequently, it's easy, and that should be the same in your practice. You see a ton of athletes every day. If you're seeing a pediatric population, iliotibial band, you're going to see in the collegiate level runners that are really doing a lot of running. I see it in soccer players as well. Conservative treatment, you can do the hip abductor strengthening, IT band stretching, ice, ultrasound. Some people go through E-stim. This is the very common stretch that's done. But, it's the same thing with the athletes that have Achilles tendonitis. Watch them warm up. Watch them stretch their Achilles before they go for a run. They're maybe doing a 30-second sustained stretch. They're not stretching. They're not really getting warmed up. It's the same thing with these athletes. So what I've found is if I can provide them a mechanical tool, the foot orthotics that they can use, and dispense some power steps. Take a power step. Put a felt wedge on the medial hindfoot and medial forefoot. See how they feel. If the patient comes back and says, man, that made my knee feel a lot better, then do a custom pair of foot orthotics that have the same wedging on it. And they'll come back to you time and time again, and you'll generate this kind of practice. This patient population is better to me than any of my diabetics and my arthritics, because this is a population where I have a positive outcome really, really quick without a lot of money on the patient's end. And they're very happy with you. And when they do, they go to this running club, and then all of a sudden I got 7 athletes in my office the next week that went into their doctor and said, hey, I need a prescription to go get custom foot orthotics at this Yankee Bionics place. That can be your practice. There is such thing as an IT compression band. I seen one woman come into my office with this band on her leg. She wears it all the time. She says, if I take this band off, I have severe IT pain. But all she's doing is taking the point of insertion and taking it to the band. It's like a Chopat strap on the patella. It's too bad this wouldn't work for our Achilles tendon patients. I can just put a band around the back of the ankle. But this is something, some people respond to the cortisone injection. A lot of runners will say, hey, shoot me, doc, give me an injection, but most of the docs don't like to do it for iliotibial band syndrome, so they get sent to me for foot orthotics. Again, number of research papers. If you guys look up the papers, there's tons of research that says foot orthotics work well, and it's all tied. Look at the bottom one, reduction of foot overpronation to improve iliotibial band syndrome in runners. This is an athletic population, and this is the population that I'm seeing come into my office more and more. So, start out with your over-count of the foot orthotics, post it as need be. Again, custom foot orthoses work for these patients all the time, but remember what I said. If it's a cavus presentation and they have outside knee pain, you're going to post the foot laterally in a cavus presentation. So if they have a plantar flex first ray or a very high arch, or you see them standing there, both their limbs on the ground, and you see hindfoot varus, you have to post them laterally. And you have to post the forefoot laterally as well, because these pathologies are propulsive pathologies. So if you're not posting the foot when the stress is being placed upon the knee, you're not fixing the problem. You need to get full-length orthotics that has the posting. Here's the thing I have a tremendous impact on in my clinical practice, and it's not just the athletic population. It's everybody that walks in my door, from the cam boot I'm fitting for Achilles tendinopathy to the knee brace I'm fitting for OA of the knee. The exact prevalence of the LLD is unknown, but when I was researching the literature out there, 65 to 90% of the general population has a leg length discrepancy. So think about that. If you look at the person next to you, they probably got a leg length discrepancy based upon those numbers. And I got to tell you, clinically and anecdotally, I see it all day. Every single day. I have the patient come in that says, oh, I had my knee replaced, 6 months ago, and I'm dealing with this low back pain in my back this whole time. And I'm happen to make them a foot orthotic because before their knee replacement, they trashed their foot and they have posterior tibial tendon dysfunction, and now that their knee's fixed, they're complaining about their foot. But the bottom line is I put foot orthotics in them, I go and measure their iliac crest, and I see they got a half-inch, quarter-inch leg length discrepancy. It's easy to fix. Ask your lab to put an additional amount on the heel, or better yet, what I do is I give them a removable heel lift. And I say, here, put this under your custom orthotic. If it works, I'll incorporate it into the orthotic. 70% of the time, the body will hurt opposite the short leg. So if my right leg's short, my left hip and low back hurts. If my left leg's short, my right hip and low back hurts. And that's because your body's trying to hold your pelvis level, your abductor musculature is firing. It's very, very easy to see. So, I can tell you I've gotten a little bit obsessive about looking at leg length discrepancies, because leg length discrepancies cause knee pain, foot pain, ankle pain, and back pain. And there's a number of reasons for it. Adaptive shortening of soft tissues, equinus contractures. I see patients that have strokes that have an equinus contracture, can't get their heel in the ground, their plantar flex 20 degrees. You know what that did? That lengthened that extremity a good half-inch. And then what did the orthotist do? Put an AFO on that patient, right? And didn't put anything on the opposite side. So these are joint contractures, ligamentous laxity, even excessive asymmetric pronation. You can clearly see just in the little stickman skeleton how that can impact. If we know it impacts the knee, we know it's going to impact the hip and the low back as well. So you would think, oh, I'm going to solve a person's back pain with foot orthotics. I do it all the time, anecdotally. I'm fixing that problem because A, the prevalence of total joint arthroplasty today is huge. Everybody that comes in my door has a joint replacement of some sort. And I can tell you that they're not all correct. So how do you determine that leg length discrepancy? I have some physicians that will order a scanogram. It's a full film cassette, and you can clearly measure from the heel to the tibial tuberosity to the greater trochanter, and you can see where the actual leg length discrepancy arises from, or which leg is actually the short leg. Physical therapists will measure the ASIS to the medial malleolus. Now I can tell you, I can ask 3 of you in this room to take a tape measure and take that measurement, and all 3 of you are going to have a couple millimeters difference in that measurement. Okay? There is no way in hell that you can take a tape measure and know, oh yeah, that's 3 millimeters. I can stretch my tape 3 millimeters. So I'm telling you, I don't use that method to measure my leg length discrepancies, because to me it doesn't matter what they measure laying down. We don't walk around laying down. We walk around standing. So I stand my patient and I put my hands on their iliac crest and I eyeball it and I say, boy, that looks high or that looks low. And put a little lift under their foot and put them in their orthotics, and you can make a big difference in these people. A huge difference. And you don't have to order a scanogram radiograph, and you don't have to lay them down on the table and take a tape measure. Use your eyeballs. It's no different than when you're in surgery trying to figure out where you're going to put that heel underneath that patient in the flat foot reconstruction. There's not a scientific measure of that. There's not a scientific measure of this, but if you're not trying it and if you're not looking for it, you're not going to see it. I received a $500 Harley-Davidson gift card this Christmas on a patient I made a pair of custom foot orthotics for. Fixed her foot problem, solved her back pain because she had a total joint replacement. She had a damn near 3/4 of an inch leg length discrepancy. She had to go through a revision surgery, and I'm sure there was some complications there. I built her foot orthotic up a 1/2 inch. She was seeing a physical therapist, a spine surgeon for a possible disc herniation. We eliminated her back pain by solving the leg length discrepancy. So just don't be afraid to look for it, because you guys can have a huge impact on this population. You can make a lot of happy people by solving their back pain. So again, many will present with hip or low back pain, and as soon as I say, is it left or right, they tell me where it is, I'm automatically looking for the leg length discrepancy to be on the opposite side of that. And this is so common, folks. I got to tell you, it's like night and day. Now, believe it or not, I know some physicians. I just recently saw a 17-year-old adolescent in Akron who had his tibia lengthened 2.5 inches by a local orthopedic surgeon using the Lazaroff technique. It took him 13 months of wearing an external fixator to lengthen his leg 2.5 centimeters. But on a 17-year-old young man, it was huge for him because he didn't want to walk around with an 1.5 inch elevation on the bottom of his shoe. And he goes through shoes at a rate of about 1 every 6 months or 6 weeks. So I'm putting an elevation on at $200 a shoe every 6 weeks for this patient. So you can do leg lengthening, and there are people out there doing it today. But I can tell you, I don't see that too frequently. You're certainly not going to see it in an adult population. It's mostly seen in a pediatric population. Dr. Lazaroff lengthens everything. If you ever, I got blessed to see grand rounds at Chicago when I was going to Northwestern Medical School, and Lazaroff came in and talked for 4 hours and presented 110 cases of limb lengthening. Unbelievable what this thing will do, as you know, but I don't know too many patients that are going to go walk around with that fixator on their thigh to solve a 1/2 inch leg length discrepancy. So they're doing, obviously lengthening. The pediatric orthopedists, they're halting the growth in the opposite leg to slow it down. They basically close the physes of the tibia or femur to slow that growth rate down, let the leg catch up with one another. I've seen that done too. I've not seen too many people lengthen a shorten a long leg. That's not too done. Osteotomies like that aren't performed too often. Yes, you can strengthen the AB and adductors of the pelvis, because if your patient has back pain that's relative to a leg length discrepancy, it's mostly their abductors and their adductors that are weak. And I have these patients that come in and they walk like, Quasimodo, they're dropping down. You obviously think they have a leg length discrepancy, when honestly, when you have a total hip arthroplasty, regardless of the way they do it, they're cutting through the abductor musculature. And most patients that have a total hip arthroplasty have very weak hip abductors, even after physical therapy. So if any of you can't stand, take one leg off the ground without your pelvis dropping, you have weak hip abductors, and you need to be strengthening them, because that's what causes these low back pain issues with leg length discrepancies like this. And I got to tell you guys, it's so easy to incorporate a heel lift in your custom orthotic. I have a pediatrician in Cleveland who has a 7/8 of an inch leg length discrepancy from a severe tibial fracture he had as a young guy. Couldn't get it lengthened, doesn't want to walk around with an elevated shoe. His patients would make fun of him. So I got 3/4 of an inch of a lift, just like that, inside of his shoe. Now he'll wear chukka boots or men's dress boots, but I can fit 3/4 of an inch inside the shoe pretty successfully. I can venture to say that if you take 1 day of your patient population and measure 1 day of your patients, you're going to see the same thing I do. About half of them have a leg length discrepancy, and if you ask them, they either have hip pain, knee pain, or low back pain. So if you just ask the question, you can do a better job with your custom foot orthotics by addressing more than just what you see. Take your blinders off, treat the whole patient, even though you're used to just looking at the foot and ankle. Again, usually a ½ inch is the max that you can fit in the shoe. And the disadvantage of this on this pediatrician, because I've been doing it with him for a long time, he's got an equinus contracture on that side from walking around with a 3/4 inch heel underneath him all the time. And he says, well, Raj, what do I do in the house when I don't have shoes on? I said, you wear one slipper. Put one Croc on. Put it on your short side and walk around your house that way. Instead of walking around the house, going out all day and working with your leg length corrected, and then come around the house and sit around for 3 hours a night, walk around with your leg length discrepancy. I've elevated slippers, but you guys can have you are the frontline people that can have an impact like this on the patient more than you will ever think, because I do it every day, and I never get an orthopedic surgeon call me and say, hey, Raj, thanks for catching that leg length discrepancy I created. I'm glad my patient no longer has back pain. They were already, lined up. What I hear is, oh, now I have to see a spine surgeon because they're thinking I got a disc herniation. Why? Because they're walking around with a leg length discrepancy. So don't be afraid to check this because it makes a big difference. Shoe elevations are normally done if is over 3/4 of an inch. Now here's the thing you got to pay attention to. I see patients that have what's called a girdlestone procedure. Do you guys know what a girdlestone procedure is? That's the removal of the femoral head in a failed hip replacement. Okay, so they basically take the proximal femur out of the patient. So they have this leg that accordions 3 to 4 inches underneath of them, and I have to put elevations on them. The reason I'm mentioning that to you is any elevation over a 2-inch height should be done at a 2-to-1 ratio. So if I have a 3-inch heel elevation, the forefoot should be 2 inches. Okay, if I have a 4-inch heel elevation, the front end should be 2 inches. You're tapering that shoe down. You can't put a huge massive elevation on these people's shoes and keep them steady up there like that. So just remember, if you have a big discrepancy, 2-to-1 ratio after 2 inches. Who doesn't have medial compartment knee arthritis? Here, this should be for you, Frank. You should have done this on you before you had your knee replaced, but it was too late by then. So medial compartment genu arthrosis, very common in the population. It's a 2-to-1 ratio, medial to lateral. And I can tell you, everybody and their brother has this. And it's funny, I found out what to do with foot orthotics for a couple ways. One way was I had patients that I was putting foot orthotics in that had genu varum of their knees, and they were coming back and saying, Raj, I love your foot orthotics, but my knee's killing me. I can't wear these stinking things. They're making my knee worse. And I'm looking, trying to figure out, did I make the orthotic wrong? Did I post it wrong? What did I do incorrectly? And, think about this. The most common musculoskeletal disorder that we see today, 20 to 40% of the people over 65 have medial compartment DJD. So this is a huge population that you're treating for plantar fasciitis, post-tib tendon dysfunction, all the other things that we see. If you decrease the varus moment at the knee, you can alleviate the compressive forces on the medial surface. So essentially, I want to create a valgus moment at the knee. I do that by creating a valgus moment at the ankle. How do we do that? We laterally wedge the foot orthotic. So I want you, the bottom paper that you see here by Dr. Keating, Ferris, and Ritter, there's a total joint clinic in Indianapolis that these guys founded. They said, this was 15 years ago, I spent time over there, and they said they did more total knee joints than any other facility in the country at the time. But this Dr. Keating happened to be married to a foot and ankle orthopedic surgeon whose house I was staying at while I was going to Indy. Anyways, we're sitting around having beer, and he says, Raj, you got to start making me some lateral wedges. I said, what do you mean? He says, oh yeah, lateral wedges work great for medial osteoarthritis of the knee. I said, well, how do you know that? He says, well, here's my paper. So this was 15 years ago. I read this paper and started seeing this. As you know, a couple days a week, I'm at Crystal Clinic, a musculoskeletal center in Akron that has every total joint guy known to man. Consequently, I see a ton of these patients being sent down to me for osteoarthritic changes in their knees. So I started using lateral wedges. I started making basically an insole and putting a 1/4-inch post on it and run it full length down. Not just the heel, not made of compressible felt, but full length on the lateral surface of the foot. Not putting any arch in it, just a lateral wedge inside the shoe placed underneath the insole. All of a sudden, I got people coming back saying, hey, Raj, man, can you make me some more of those things? I like that. And then I got a couple orthopods starting sending them down asking for lateral wedges because the patient went back up and said, hey, doc, this wedge worked great after you gave me my injection. So I got 2 physicians now that do injections, whether it's the Hyalgin, Synvisc, or a cortisone injection, that ask for a lateral wedge to be done at the same time as they're doing that. And we kept seeing these patients back with a good degree of success. So the most important thing is that the wedge has to be a minimum of 5 millimeters, because I've tried less and it wasn't effective. And it had to be full length. It at least has to be under the 5th metatarsal head. So you're basically doing a valgus wedge to the bottom of your custom orthotics. Now your podiatry labs aren't too well versed at providing valgus wedges, especially of this degree. So what I started doing was, if the patient came in and had a functional orthotic, I just glued some EVA on the bottom of it and started wedging them laterally to see if it was going to make a difference. Huge difference in these people's knee pain. Matter of fact, Dr. Ritter told me he felt that the initial use of a lateral wedge was as pain relieving as any cortisone injection he's ever put in. So it's frontline treatment, and you guys, I know you're seeing osteoarthritic knee patients every single day in your office like I am. There is no reason that you guys couldn't be incorporating lateral wedges into your orthotics. Dispense a power step with felt on the lateral border. These people are going to come back and ask you for more pairs. And I've seen it happen in my own clinical practice. If I'm making an orthotic for an osteoarthritic knee patient, though, I choose not to do a functional design because I want to be able to lower the longitudinal arch if I have to. So the last thing you want to do is make a high arch and a high lateral wall. So on those patients, I'm taking a weight-bearing impression of their foot, so I'm allowing them to pronate and then putting the wedge on the outside. And I'll use a softer material because soft shock-absorbing orthotics work better in my osteoarthritic population. Let's face it, most of these people are 45 and older. We could all stand to use a little softness in that point in time. Now, I will tell you, I'm not as successful on my patients that have lateral compartment OA of their knee. It doesn't work as well because I can put a hellacious medial wedge under the foot, and because of the ability of the foot to invert twice as much as evert, the lateral wedge has a very positive influence. The medial wedge I don't do as well with, and I've done several females with lateral compartment OA, and some of them say it's definitely helpful in the early stages, but it's much more difficult if they have lateral compartment OA of the knee. I'm not as successful with the medial wedges. You're going to see people walking around with these unloader braces. That's essentially what they are. This is a valgus-producing or varus-producing knee brace. So basically, I call it the best analogy I can give you how they work is if you have a tomato plant that gets heavy and laden with fruit, the tomato plant does this. So the first thing you do is you put a stick in the ground and you wire the tomato plant to the stick. So this knee brace is my stick and your knee is my tomato plant, for lack of a better description. But these things have become very effective. And now when I dispense the knee unloader knee brace, I'm putting a lateral wedge in the patient's shoe simultaneously. Just a lateral wedge, that's all I'm using. And I'm not using felt, and I know there's a lot that sell those felt lateral wedges. You see what a felt pad looks like in about 3 weeks' time under a guy that works at a factory? It's non-existent. So I'm using this in conjunction. So here's a fluoroscopy of a patient. You can see the medial compartment is bone on bone without their knee brace on. I put a lateral wedge and their unloader knee brace, and now look at the joint space on the medial side. Exact same place in the gait cycle, and you can see the opening of that joint space. Does that always equate to pain relief? Not 100% of the time, but certainly when you see that kind of change, you're basically shifting the weight from the medial compartment of the knee that's osteoarthritic to the lateral surface that still has some cartilage left. And I got to tell you, this has been one of the easiest things. I charge $30 for a set of lateral wedges for my patients. They think that's the best $30 they ever spent. They'd rather do that than pay their copay for physical therapy. The last one I'm going to talk to you about is sometimes very difficult to manage, medial tibial stress syndrome, or shin splints, or stress fractures of the tibia, or periostitis, for lack of a better term. And I was going to ask Dr. Mori if we could, on these shin splint patients, if that tool that he has wouldn't be valuable to use on these people, because I don't know if any of you managed any 15-year-old cross-country runners with shin splints. They're in my office every other day. My shin's hurt, I gotta run. And why they want to do this, I don't know, but we got to make them happen. So most of the time, the orthopods or whoever's going to order a bone scan to see if there's a stress fracture and or is there an uptake with the tibia, where is it located. So it's very easy to see, and I don't think you need a bone scan to determine that they have medial stress syndrome. But I guess if you own the scanning facility, you're going to order a few of them at times. So that stuff happens. The etiology is mostly running an athletic population with overpronation. Cross-country and high-mileage runners are prone to this big time. I have a man that is a difficult patient. He's a century runner. Do you guys know what a century runner is? He doesn't go out unless he runs 100 miles. So his wife takes him down to Martin's Ferry, drops him off with a cell phone, a fanny pack, and some money, and he runs home. Okay? From Martin's Ferry, West Virginia, or from Mentor, or wherever his wife drops him off that day. Guy averages about, on an average, I think he's just a professional runner, he says he averages 350 miles per week of running. Obviously, you know, obsessed to say the least. But the bottom line is, on these patients that have medial tibial stress syndrome, the frontline treatment should be custom foot orthotics. And you guys should be doing them, because they're not always well done everywhere else. Now, there's two classifications. Anterior medial, which is the most common area, or posterior medial. And I can tell you that both of these, if you look at the location, one is the origin of the posterior tibial tendon. The other one is the origin of the anterior tibial tendon. When I see the anterior tibial tendon patients, those are the cross-country patients that run downhill. So their anterior tibial tendons trying to decelerate the foot as they're running downhill. Okay, the medial patients are just straight from overpronation. But I got to tell you, look at the cross-country runners with their clinical presentation. There's tons of papers. I only quoted this one because it was a good one that said, use of foot orthotics and calf stretching should be frontline treatment for medial tibial stress syndrome. That's you all day long. That's your patient population that you could be prescribing and or fitting and dispensing. And this is the population that would serve best with foot orthotics. Do over-the-counter power steps with a medial post on them. Again, if you're going to post them, the biggest thing that fails is not having medial forefoot posting. So realize, if you got hypermobility of the first ray, forefoot varus, these people hurt at the propulsive phase of gait. So if you're not bringing the ground up to the medial ray and giving them some form of medial posting, most of the time the foot orthotics fail. And I can tell you, I take physical therapy orthotics out of their shoe, I put my full-length multi-density orthotic into the shoe, and it solves the problem because of the medial posting. Not the material composition, not the position you casted them in, but the medial posting to the forefoot has been the most effective thing that I've done in treating these athletes with medial stress syndrome. Now, the ones that have lateral anterior shin pain, sometimes it is a cavus presentation. So what I tell you is post it according to the foot. If they have a cavus foot, post them laterally. If they have a planus foot, post them medially. And it's usually somewhere in between that. And that works. And I can tell you that for whatever reason, this population is increasing in my office. And I don't mind it because many of these athletes, this is a cash pay population. So they come in, they say, how much are your foot orthotics? $432. Okay, I'll have a pair. Can you make me another pair so I don't have to transfer them from this running shoe to this running shoe? Sure, I'll make you as many pairs as you want. So this is a population that are in your office every single day that you could be taking care of. And I'm just going to give you this one case because it's a kid I just saw yet this week. He came over to me from Pennsylvania. Think about this. This kid went to see a doctor in the Cleveland Clinic, and the doctor sent him down to me for foot orthotics from Pennsylvania because he had medial tibial stress syndrome. Now, you can look at him. You can see the tibial varum. Look at the bow of his tibia. Look at that little medial bow there. So you can see right out of the box he has tibial varum. You look at his hind foot, it really doesn't look significantly overpronated. I did the double limb heel rise. I just wanted to see what the function of his posterior tibial tendon was to make sure it wasn't attenuated or there wasn't anything bad in that. And he did that great, has no problem, but he had a pair of orthotics that a physical therapist had provided for him from the school that he goes to in Pennsylvania. And I asked him, I said, why'd you guys come all the way over here to see a doctor for this problem? There wasn't any professionals in Allegheny or Penn or wherever you could go. Well, they just kept pity-patting him around. They'd try some ultrasound. They'd try this. They'd try that. Well, did you try telling them not to run so much? But that doesn't come out of the mouth in the athletic population, so you have to just keep treating the athlete. This kid runs 25 to 35 miles a week, and he's doing cross-country. So, I'm looking at this, and I'm not seeing anything of any huge anomaly as far as his alignment. He's got a beautiful aligned hind foot. So you'd look at this foot and you say, why would I put foot orthotics based upon that foot? You put our foot orthotics because he's got medial tibial stress syndrome. That's why you put foot orthotics on him. And if you use that as your diagnosis, insurers pay for foot orthotics for medial tibial stress syndrome. And there's no pathology involving the foot. Medial tibial stress syndrome gets foot orthotics covered. Who'd have thunk that? And you can easily diagnose that. So some people call it posterior tibial tendonitis. Some people call it a tendinopathy. It's just medial stress syndrome. So I made a multi-density foot orthotic, made standard models. The only reason I'm showing you this foot orthotic, if you look, I wanted you to see the striation of the medial forefoot posting. Do you see how far that extends up into the orthotic? Right where his little name is, right where that little name goes across there. You can see how far I extend the medial posting. And that's probably at minimum a 5 millimeter post under the hind foot and forefoot. Okay, and the only other reason I did this design is because he's cross country. I didn't want something too rigid in his shoe. I wanted to be able to absorb some impact as well, because I have seen some relationship of some stress fractures just from the sheer pounding mechanism of what these runners do. So really it doesn't matter. I don't think it matters as much the material composition as it does where your posting is. Did you post them correctly? And the only other thing I've noted is if I use a rigid orthotic, everyone has to do some arch fill. If you're filling the arch because of the rigidity of the orthotic, you're allowing pronation to take place. So what I've found is if I use a multi-density orthotic on these runners, it's a little easier to get used to. I don't have the incidence of blistering, and I have a better amount of posting under the foot because I can use a softer material to block the pronation. So it's anecdotal. I have no science behind this. I just have a lot of years of doing this, and I found that a softer material composition for these medial stress patients seemed to work better, particularly in the adolescent population. So anytime you see these patients, again, it's not necessarily the composition of the orthotic, it's how did you post them, and did you post them enough? Because I can tell you, when I'm replacing foot orthotics pretty regularly, there's never enough posting on these, and that's where they fail. And the arch fill also fails. So think outside the box. Don't always just put a functional orthotic underneath them, because that's the lab you check it off to. I can't use the same material composition in my orthotics for this population, so you shouldn't be doing it either, because you're seeing the same patients I'm seeing, and this is a good population for you to care for. And if you get a reputation in managing the runners and the athletes, they flock to you. They are standing in a running club, and they're going into their doctors getting prescriptions to come have me evaluate them for their shin splints or their leg pain. That can be your office that they're driving in, and you could be dispensing those orthotics, and these are no-brainers. It's not like the Morton's neuroma patient that I'm going to see 16 times to make them better. I put these orthotics in, they go away, they come back 6 months later, say, hey, Raj, make me another pair. I like those things. And the parents will do anything. They'll pay anything. Wouldn't you guys pay anything for your student athlete to be able to continue to do the things they love? That's the parents I have in my office every day. So,
How long does it usually take for them to heal?
Settle down. If they do their calf stretches, his question was, how long does foot orthotics take to settle down medial stress syndrome? So one is, how long have they had it previously? What have they tried before? But B, all these people have gastroc contractures. So if they're not stretching, and I tell them this, I say, if you don't stretch, you probably won't get better, because their tight calf is what's driving the overpronation. So you need to enforce the gastroc stretching on these patients. In the one paper that I read on this, they said that the stretching to the gastroc was as important as the mechanical wedge of the orthotic. So I can tell you this, I've seen a few patients come in. I actually have a doctor. I have to dispense these compression calf cuffs. And this has a rubber bar that goes down each side of your tibia to drive into the origin of the posterior tibial tendon or the origin of the anterior tibial tendon, and then they strap it down. Doesn't work worth a crap. Okay, I can tell you, I have patients come in, I got a doctor that orders them, and every other patient comes in and say, can I return this thing? Because it doesn't work and it's cash pay. So, you know, it's mixed outcomes, and I wouldn't recommend that. So the reason I brought this to you is, one, Dr. Hintz thought this would be a good idea to talk about something that actually didn't always involve the foot. But B, I'm increasing my business dealing with athletic-related patients with a great degree of success. And just like you guys, I have to carve a niche out in this business because everybody and their brother is making foot orthotics. But if you can become good in the athletic population, learn a little bit of the lingo that I just shared with you here, think about the orthotic composition, it can drive business in your door. These people talk. There's blogs out there that are using my name and saying, go see Roger. He's a guru of foot orthotics for running problems. That can be you guys, okay, especially if you don't have a Roger in your backyard. So I can tell you foot orthoses are successful in treating a ton of pathology that doesn't involve the foot and ankle. And you guys can get paid on that all day long. There's no reason you shouldn't be doing this in your practice, because I'm doing it in my practice, and mine's pretty much a mirror image of yours, except I'm just not doing surgery. So, and I see patients 5 days a week, and you guys don't have to. So remember, the toe bone's connected to the ankle bone, is connected to the knee bone, is connected to the hip bone. And that sounds so rudimentary, but I'm a pretty simple guy. And I'm a mechanic, and I go in there and I look and say, what's that leg doing that's causing this pain? It's not rocket science, folks. It's really very simple. So take advantage of your biomechanical expertise, take advantage of your labs, and take advantage of me. If you want to send the patient to me, I'll take care of it, and I'll make you look like a hero. So thanks for allowing me to flap my lips to you for 23 years in a row, and I hope I can have something of value next year as well. But it's nice to see all these faces in here from 5 at 6 o'clock on a Friday night when there's a bar right in the same building. Thanks. Appreciate it.
Okay, I want to thank everybody for attending. We go straight into our workshops now. For the workshop in this room, we're going to set up and then we're going to re-scan. So people are going to have to exit and then we're going to open the door and scan from one direction here. The other two workshops are down the hall where we were eating. And remember, only scan for one workshop. You can only get one workshop, even though you can mosey around if you want. Well, I don't, shoot. They didn't.
I don't mess with you.